Hello, everybody. Welcome to the Autism Consortium of Texas. Really happy to have y'all here, and this is our first seminar for the fall. So we hope to do these every month, and feel free to join in. So I want to let you know that our speaker today is Dr. Monica Gordillo. So Dr. Gordillo just received her PhD this last spring, and I was on her committee, so I was really excited. When I was listening to her research, I was like, wow, we really need to get this out to our community because it's really useful information for working with Latino populations. And so really excited. And currently she's a psychology postdoctoral Len Fellow at Nemours Children's Hospital in Delaware. And she has her doctorate in clinical psychology from Boston University. She has experience delivering parent-mediated behavioral interventions and psychological treatments to children ages 2 to 17, primarily kids with autism, and also has done work on a sibling study, really understanding the experiences of Latino siblings with autism. So he's really done a lot of great work with the Latine community. And so, as you already know, the topic is delivering quality care to Latine families of children with intellectual and developmental disabilities. And I'll look at how Latine parents evaluate care quality and express care satisfaction or dissatisfaction. So we're excited to hear from her. And so now I'll turn it over to Dr. Gordillo.
Hi, everyone. I'm really excited to be here. So again, my name is Monica Gordillo, and as Sandy mentioned, I'll be talking about research that I've done for my dissertation, primarily on how Latina families of children with IDD evaluate service quality. And I think just before getting started, I did want to take a quick moment and mention how appreciative I am that I was invited during Latin American History Month. I think when you're doing this type of work, either clinical or research, it's kind of easy to forget or to feel like, oh, I think I'm the only one that's really interested in this topic. And hearing how many people registered for this was just really, really nice to hear. So there is an audience and there is interest for this. Okay, so a little bit about myself before getting started. I'm a second generation Nicaraguan and Mexican immigrant. I'm a native Spanish speaker. I have personal family experiences with IDD. And professionally, as Dr. Magaña mentioned, I'm a postdoc at Nemours Children's Hospital, where I work at the Swink Autism Center. And within research, I have primarily done qualitative work with Latina families of children with developmental conditions. But a really important aspect of my research is my use of community advisory boards, which I listed here. Advisory boards have helped me in the past and also with this research formulate my research questions. They've informed my methods, helped with recruitment. They vetted my interpretation of the data I gathered. So this work would not have been possible without them. And on a logistical note, I can't take credit for, these are a lot of community advisory boards. And in my lab, we shared advisory boards amongst myself and a couple of other projects. So we helped each other out to co-lead and co-create some of these as well. As a general note on language before I get started, just wanted to bring your attention to my use of the term Latine, particularly when referring to the general Latin American population. But I'll also use a more gendered term if and when it reflects on just an individual's personal identity. And I use Latina because I want to use a term that aligns with just my value of inclusivity. And Latina is also a word that sounds, I guess, like phonologically harmonious with the Spanish language, at least relative to a term like Latinx. So that's just a personal preference, and it should not be construed as me saying that this is the right way to refer to anyone in this population if that is not their preferred term. Okay. And to introduce the study a little bit, Also, I'm not sure if anyone's monitoring for questions. I don't have access to the comments. I'm okay with being interrupted with a question if that's what people are comfortable with.
I'm monitoring for questions, and so
Perfect.
we can take them. I'll let you know if we have some that pop up. Would you prefer that I interrupt you or that throughout the talk, or that we save them for the end?
I would be okay with interruptions, but
Okay, I'll
if
let
it
you
does
know.
feel like it's getting too much, I might let you know, but I'm okay with interruptions.
Okay, great. Thank you.
Great. So as a general note, IDD is a broad umbrella term. It includes a number of conditions like autism, pervasive developmental delays, genetic conditions like Down syndrome. And generally speaking, children with IDD can often have complex presentations. Complex meaning can include other IDDs, can include chronic medical conditions, mental health conditions as well. And they tend to have a greater need for, at least relative to children without IDD, for healthcare support services and developmental services. Developmental services including things like occupational therapy, speech therapy, physical therapies, early intervention, those kinds of services. So within the IDD population, Latina individuals with IDD have less access to these services that I just mentioned relative to white individuals with IDD, and they also tend to receive worse quality of care. So there appears to be this cycle of, in this graphic below, this cycle of they have poor access to care, so they're not getting the needed services. When they do get these services, those services tend to be poorer in quality relative to white individuals with IDD. However, there is some research suggesting that if we can improve one of these bubbles or squares, we can improve the other one. So by improving the quality of service, we are likely to see some of these disparities in service receipt disappear. Not all of it, some of it, but service quality, that term is very poorly understood for this population, making it difficult to know how to improve, even if we were trying to improve it. And just to make sure that we're on the same page, the way that I'm describing service quality is perceptions of how well service interactions address the needs and preferences of families. And when we think of service quality, we typically think of the individual interaction between the provider and the caregiver. Or I guess on one side, the caregiver and the child, and on the other side, the provider. But what we also know is that these interactions don't exist in a vacuum. And it's likely that aspects of context and culture have an influence on that interaction. And influences can be also on those perceptions of care quality. So regarding the Latina cultural influences of interest for this project, Latina cultural values, generally speaking, are very interpersonal in nature. For example, personalismo, pictured here, refers to the preference for making personal over professional connections. So in other words, this is a preference for informal, long-lasting, and almost like friends over colleagues types of interactions. And these personal connections can be made through expressions of simpatía and respeto, which means being friendly, courteous, while at the same time also avoiding social conflict. And inherent in this is really valuing having others see you as easy to get along with and respectful to others. The goal of these expressions is to develop interpersonal trust, or confianza, which is the Spanish word for that. So in the context of medical mistrust, it's kind of like, with whom can you let your guard down around? However, it's unclear how these values affect the perceptions and behaviors related to service quality. And just so everybody knows, these aren't like discrete qualities or values. There's quite a bit of overlap across these, But just one way that I conceptualize these is I see personalismo as more of this like individual internal preference, whereas simpatia is more of an external individual quality of just how you project yourself towards others, while confianza really requires this like two-party system of just like a way to qualify the relationship between at least two people. Okay. So I will be discussing two studies in particular. Part of my dissertation was like a 3-study model. So if I have time, I'll like briefly talk about that last one. But study 1 examines how Latina parents evaluate service quality. And I was also really interested in presenting practical recommendations for how to deliver good quality care to this population. And study 2 explores the behavioral signs providers can look for within Latina parents, just to know whether or not parents are satisfied or not satisfied with the quality of their care. And again, I'm really interested in how culture and context relates to all of these findings. So I'll be talking about that throughout. So because I'm not totally sure of the composition of the people in attendance here, I will very briefly go over the methods for this study, but please feel free to interrupt if there's anything that it would make more sense for me to be a little bit more detailed with when it comes to methods or any part of this. So very briefly, recruitment was primarily achieved by sharing study information with our community advisory boards and research partners. They did a lot to help spread the word, and most, if not all, participants were recruited really through word of mouth. Regarding eligibility, I recruited Latina primary caregivers of children with IDD. Parents needed to have had at least 2 service interactions for their child in the last year. And service providers delivered healthcare, family support, or developmental services and had had at least 2 service interactions with Latina families in the last year. And here I use, as I mentioned earlier, developmental services, again, to mean services like early intervention, speech therapy, occupational therapy, ABA, and so forth. All study visits were virtual and consisted of an in-depth semi-structured interview and online questionnaires. And just as background, these interviews were semi-structured, which basically means that it's designed to be a lot more conversational relative to like a question-answer format. And so I, as the interviewer, knew, generally speaking, what topics I wanted to have been discussed. And I really try not to limit, constrain, or really lead the conversation in any way unless I have to. And regarding data analysis, qualitative data were analyzed using something called applied thematic analysis. It's a form of qualitative data analysis, which seeks to identify patterns and repetitions within interview data. And this methodology also informs the number of participants enrolled. So basically, once new participants' interviews aren't really introducing any new information that maybe earlier participants hadn't talked about, recruitment and enrollment generally slows down or basically ends at that point. And quantitative data were analyzed using descriptive analyses. And just as a note as to why I chose this methodology to understand this particular topic is that I could have created a questionnaire on how different quality indicators, like which ones are families looking for in these service interactions. But given that this is an area of research that's been really understudied, and given that I'm not a parent of a child with an intellectual or developmental disability, nor do I hold an IDD identity, I'm not sure even where it would have started or what that questionnaire would even look like. So I went with this other approach where I really needed to check my own IDD experience assumptions at the door and start by learning from families and from providers themselves about what their experiences have been. Okay. So regarding the Latina mothers who participated. I recruited 10 in total. And again, that 10 kind of refers back to what I explained earlier of among Latina mothers, there was a lot of repetition kind of from the beginning. So we really weren't looking to go to get that number higher. Within those mothers, most were immigrants from Latin America. Most were only comfortable speaking either Spanish or Portuguese. We had one Portuguese speaker from Brazil. And 2 mothers had more than 1 child with a diagnosed IDD. And children's ages ranged from 5 to 17. Mothers reported that over half had an autism spectrum disorder diagnosis, and over half had a chronic medical condition. And it's important to note that I listed here ADHD under diagnoses, but no child had an isolated diagnosis of ADHD. ADHD tended to be the a co-occurring condition to another IDD. Most of the 16 providers delivered medical or behavioral health services, which includes psychology, followed by developmental services, and then by service coordination services. A majority of providers had graduate degrees and had been delivering care for over 10 years. And most providers identified as white, but we also included enrolled Asian and Latina providers in the sample. And it might be a little tough to see, but basically this last picture here is showing how a majority of providers regularly delivered care to the populations of interest, which were Latina, non-English speaking, and IDD populations. Specifically, they interacted with each of these populations at least once a week, but often multiple times a week. Okay. Oh, and one thing I forgot to mention is that within our sample, we weren't geographically constraining where we recruited from. So we did have participants from Massachusetts, Texas, California, Oregon, Arizona. I think I'm missing one more state, but this does represent perspectives across different states of the United States. Okay, so before I go into the results from this study, I just wanted to mention that unfortunately what I did not find was that there's this like magic formula that you need to follow and then all Latina families are going to love you. There will definitely be cases where it's just not a good fit for a number of reasons. And the following results are more of a general guide to be used for you to fill in with all of the nuances that are missing, given your specific context as a provider and given families' context as service recipients. So in other words, the examples that I provide here, it just may not be possible given your specific context, but it's important to still think about how the underlying principles still apply. So as for study 1 findings regarding how Latina parents evaluate their children's services, big picture, providers and parents overlapped almost entirely across this and also the next study's findings. But first and foremost, the most important thing that Latina parents evaluate is providers' relationship building skills, relationship and trust building skills. And only after do they then evaluate the provider's level of expertise in the specific field. So from the provider's perspective, this in and of itself is a pretty interesting finding, just because providers' formal training generally consists of building up a lot of clinical expertise and not necessarily on these relational skills. And when trying to consider why is relationship and trust building prioritized over professional expertise, here's where we see a little bit of some identity intersectionality come to play. Where, as I introduced earlier with the Latina cultural values, this is mapping on almost exactly with the cultural values of personalismo. Again, that preference for these personal level interactions over the professional or formal ones, and confianza. But this also lines up with the IDD experience. So for providers, prioritizing building trusting relationships becomes more important when you work with IDD populations, because these are the populations that often need ongoing and often coordinated supports, which is different from situations where, like, maybe you get a cut and you need stitches, and all you likely need in that situation is that one-time touch point with a provider, maybe a barely competent provider, but not a ton of trust goes into that in order to get stitched up, at least not as much as with some of these other populations. So again, the goal for providers is to build trusting relationships with families. And when it comes to the type of relationship to build, providers should aim for a collaborative relationship and not a hierarchical one. So this is the difference between I am your doctor and you should do what I say, to I am your doctor and we are a team, and that team makes decisions together. And to achieve this type of collaborative relationship, participants recommended specific domains of relationship building that providers can use to convey simpatía and respeto to Latina families. Again, this is about how you are projecting yourself towards others, in this case, Latina families. So going into these more individual or more specific ways of how to convey simpatía, participants described how speech and communication are very foundational to building relationships and trust. And when it comes to spoken language, it's important to anticipate and bridge any language comprehension gaps. So language comprehension gaps, like the obvious example is when providers and parents speak different languages. But language comprehension gaps can also occur even if providers and parents both speak the same language. And here, I think it's really, really important to remember that as providers, it's easy to forget that jargon that we use every single day is not simple language. We very readily, with a lot of repetition, start to believe that, as we see in this example, these terms that we throw around every day just aren't part of everybody's vocabulary. So here, this early intervention provider described how terms like IFSP, PT, OT, ED are things that even if the parent has comes from like a very well-educated background, you still have to do your best to bring it down to a third grade level. And here, I think it's also really safe to assume that you as a provider may not be aware of just exactly what are the terms that you lose families on. So I think going in with that kind of mentality and knowing that you're going to have blind spots essentially is really important to help you try to catch them more. And we could also think of another example with like health insurance, where if you are working with Spanish-speaking immigrant families, they may come from a country where the concept of private insurance companies weren't really a thing. And so, especially now working within a hospital system, I do hear insurance terms being thrown around a lot, and I barely understand these terms. Actually, I don't understand a lot of them. So just putting ourselves in the shoes of families for whom may not have grown up with this terminology is a really important first step to bridging those gaps. And then more specifically, when participants also had advice when working with interpreters or translators, they mentioned that if something sounds off in the interpretation being provided, or if you just know that whatever you are communicating is like complex or nuanced in some way, it's okay to ask an interpreter to repeat back to you what they said to the family. And it's encouraged really to repeat yourself with that same message, just in a different way, to highlight to the interpreter and to the family what that nuance is. Next, they emphasize how providers should remember that they should use communication to let families know they're being heard, to engage families in the service delivery, and to empower families. So from others, some of the more memorable providers were providers who communicated to them just how important their voices and their roles were for the service interaction and also for the child's well-being. And in terms of specifics, providers and parents talked a lot about it's important to use reflective listening approaches. So that would be like if a parent brings up a concern at the start of session, throughout your session or throughout your appointment, really taking any and every opportunity to kind of insert back parents' exact words, exact vocabularies, and trying to connect how what you are talking about in that moment does relate back to what parents brought up. Also explicitly teaching parents what their roles are in the service interactions, explaining to them that they do bring an expertise into that relationship with you and that that expertise is valued. Being transparent with families was a really big one. So if there are times where if you're a clinician and you're doing some like clinical decision making in your head, it's okay to voice that out loud and then bring parents into that decision making process so that it's more of a collaborative effort. And then teaching parents effective advocacy skills that they can use not just in the service that they are engaging in with you, but also across services. This includes knowing if a parent is going to an IEP meeting the next day and reminding them of what their rights are, reminding them that they can request for an interpreter if there isn't one already a part of that meeting, things like that. Next, participants described how providers should focus on enhancing the family's connectedness, which has a little bit of nuance to it, but essentially it's important to remember that for parents, the IDD experience can sometimes be pretty isolating. So the goal here is really to increase the family's sense of connection, both to you and the community within that IDD parenting experience. So like I said, it includes making families feel like they have a personal connection to you, the provider, which means that as a provider, you should really get to know the family and the child beyond the child's diagnosis or presenting concerns, which leads to this quote by an RBT, who's also Latina, mentioning how in her role, she does supervise other behavior therapists. And she mentioned, I tell therapists, if I see you come in and that client, so the child, is not wanting to even be near you, I'm going to say, are you giving him the space? Are you listening? What is the child telling you, even if he's not saying anything? And this behavior therapist was very, very big on that connection, or I think within the RBT world, it's called pairing. So she's really doing a lot to examine others' ability to pair with families. So key here, like I said, is meaningfully connecting with families on a personal level. You don't speak Spanish, maybe learn a few words just to show families you have an interest in learning more about them or in aspects of their culture. Asking about how different family members are doing, learning family members' names, or even using little reminders to remember people's names. But enhancing connectedness also includes connecting families to support services. So once they're done with your appointment, they still feel like they're connected to needed services. And also to the larger IDD caregiving community, which can include support groups. But I think inherent within this is families were also adamant about they don't just want to be the recipients of support. They also want to be in situations where they're providing others with support. So that can include providing other parents with support, but also even if there are situations where they could inform providers on how to deliver care or help out clinics on how to make the clinics a better environment for other families. Those are situations also of empowerment for families. Participants also recommended providers demonstrate their commitment or that families are worthy of providers' time and attention. That includes looking like you're fine with the time that you're spending with family as opposed to being rushed. Families talked about having a very, they're very quick to recognize when a provider is just kind of itching to go because they've got a booked schedule that day. If you told families you'd follow up, call to follow up, even if you don't have any updates. if you said you would get to parents information by Friday comes around and you don't have what they needed, it's okay to call and say, hey, I don't have this thing, but I have not forgotten about you. I know that's something that I need to do. I'll let you know when I do that. And this also includes minimizing provider turnover when possible. And I know that sometimes that's not always possible. Okay, I just go ahead and skip this last quote. When it comes to providers' expertise within their specific field, providers and mothers were pretty emphatic about this being kind of secondary. It's important to an extent, but often not as important as relational skills. And especially from the perspective of parents, one thing that both sides talked about, but it's really important to know as a provider or even a researcher that you might have a more, I don't know if harsh is the right word, but you may be evaluating your clinical expertise on a harsher level than families are. Because from families' perspectives, they may not even know what your actual job title is. And I've had quite a few providers tell me that they've been called a lot of things: the nurse, the social worker, the doctor, the lady, the therapist, even if that's not your job title. Because from the families that I interviewed, I got a lot of like that teacher or that doctor, and there wasn't a lot of other job titles that they talked about. So I think that's just going back to your professional expertise is just kind of assumed if you are in a doctor or doctor type role. And it's harder for families to evaluate that, at least to the standard that you are evaluating yourself. Regarding whether a provider shares a family's cultural background, or if the provider speaks the same language as the family, participants said that it was helpful but not necessary. But this slide should really have like a few asterisks in it. I do want it known that I did not ask, at least not in a systematic way, whether or not families had any kind of exposure to another like Spanish-speaking provider or another Latina provider. So this could just really be reflective of if families haven't had that experience yet, they might not know that, oh yeah, that's something that I would really want. All right, switching gears a bit to the second study on how Latina parents express service satisfaction to providers. So when providers have successfully built that trust that I talked about in study 1, participants talked about how you'll be able to tell, but basically there's going to be a clear presence of positive feedback. Specifically, when families are satisfied, parents will verbally and physically express gratitude, appreciation, and loyalty. They'll be willing to be vulnerable and unguarded with providers. And with this one, I think it's okay to assume that going into a service interaction, families are going to be a little guarded, and there might even be a little bit of mistrust going into that interaction, and they'll have a wall up even. And I think looking for those moments when families seem like they're putting down that wall, and you're seeing more of like a range of facial expressions. If families are commenting on about their personal life, those are examples of families letting their guard down around you. I also talk, like I mentioned, talking about personal topics that might only indirectly relate to the service encounter. Again, during or across appointments with families, you may see how families are wanting to make this switch with you from a formal professional relationship to an informal or personable one. One Mexican American mother said that when she feels more comfortable with you, I'm gonna be talking with you like, oh, have you ever been to Mexico, doctor? Oh, you love tacos too? We make the best tacos. Basically, to sum it up, if you start talking about other things besides the medical issues, you know you're getting somewhere good. This personable relationship building continues to the point where if you've really earned that family's trust or confianza, you essentially become their person. That's where this mother comes in and saying that once she found the right doctor for her child, she's not leaving that doctor, she's staying with that doctor until her child becomes an adult. And if she had another child, would still be the same doctor. So even, and I heard this across other mothers as well, of like really not wanting to leave that provider, or if a family is offered, like if this is a busy clinic and family needs to see a doctor or some other provider, like if the family is willing to wait a little bit longer, but specifically to see you, that's also a good sign in terms of giving you some positive feedback. Unlike with service satisfaction, where what you're really looking for is like the presence of some positive feedback from families, participants noted that when Latina families are dissatisfied, you're actually looking for the absence of any feedback, especially negative feedback, which will be incredibly hard to spot sometimes. So when dissatisfied, rather than give providers any kind of direct feedback, and this includes when parents like aren't necessarily in agreement with something you said, or even if parents are just confused about something you said. This also includes parents' willingness to voice questions they have. Latina families may prefer to stay quiet rather than voice concerns. They may send some mixed messages and then fade away over time. And they may also switch service providers. So essentially, families may seem agreeable to you and the service you're providing, as explained by this behavior therapist, who said Latina caregivers will yes us to death. Like they'll say everything's fine, everything's great, yes, 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 until they discontinue their attending that service with you as their provider, or just leaving the service entirely. And I think one point that I wanted to make here is that this is pretty important, because for providers in these situations where negative feedback could have been given but wasn't, providers aren't getting that feedback on how to improve their service delivery, like what went wrong and how do I make it better. And from families' perspectives, if it's not voicing any concerns until you decide maybe this isn't for me, or you decide I need to switch to a different provider, any time spent switching providers is time that could have been spent receiving services. And when I asked mothers in the study more about, well, why not bring up to providers that you're concerned, or that you disagree with something, or that you had a question, the answers that moms gave here kind of really nicely align with this idea of simpatía and respeto, where they couldn't really give me a lot more beyond, well, voicing concerns just feels wrong. It feels like confrontational, and being respectful to others is what feels right. And what's the point of speaking up? And that spoke to moms really having difficulty with seeing any positive consequences that can emerge from, at least from their perspective, something like confrontation or conflict. Okay, so we've talked about that individual level interaction a lot, and the cultural influences that take part in that. But we haven't really discussed contextual influences. And I do want to, because I also recognize that I can talk kind of fast sometimes, so I want to pause here for questions, and before going on, just see if anyone does have a question. I'm happy to answer now, or I can continue.
Hi, so there is one question. So someone said, regarding talking about personal topics, have you found it better to let families lead that progression? And is it generally well or poorly received if providers initiate more personal conversations?
Oh, that's a great question. Can you repeat the first part of that question?
Sure. Regarding talking about personal topics, have you found it better to let families lead that progression?
I think it can depend.
Mhm.
But yes, I think it can come off as a little invasive sometimes if you as a provider are kind of jumping straight into asking a personal question of a family. And in those situations, there has to feel a little, going back to that, it has to feel collaborative. It has to feel like we're on an equal level and not necessarily hierarchical. So if you were a doctor going in and starting to ask families personal questions, that doesn't necessarily feel like we're on the same level or collaborative. So I think one thing that I like to do is think about ways in which, like, whatever family's sharing with you, is there something personal that you could share about yourself, and being willing to offer that up and giving families that opportunity to offer back in return if they would like. But then I think as you have more appointments with this family, or as you feel like that guardedness is maybe coming down a little bit, taking a chance and asking a little bit of a personal question, starting off small, seeing what family's response is and building off of that.
Sure, thank you. We have another question.
Yeah.
So on the Latinx caregivers will yes us to death, how
Mhm.
can providers recover from that point? What would you recommend? By recover, I mean, how can providers manage to re-engage the patient?
That is a great question that I was kind of hoping not to get, but I'm glad I got it. So I guess the answer is a little complicated, but essentially, the person who said that quote was a Latina provider who, from her perspective, really knows the culture. And these are situations in which she and also the other Latina providers identified. Even I'm having a hard time telling when this family is just like yesing me to death, or if they're actually like really in it and really liking the service. So I think the short answer is there are a lot of times when it's just not going to work out, and if you're not catching it, it might be too late. But I think the positive message there is really, when White presented these two studies, is I think it's worthwhile to put in that effort of relationship building at first, getting to know that family, and going back to one of those quotes that a provider said about how, are you identifying what that child is trying to tell you, even if that child's not saying anything? So have you really gotten to know the family enough to know, like, oh, they're giving me the signal of they're yesing just a yes and they're not really in this? And I think that's something that some of these providers said, of like, I could tell when this family was just saying yes just to say yes, and trying to work on having more of a conversation on, like, why is this a service that family would want, and working more on those shared goals between families and providers. I hope that
Mhm.
answered.
Yes, yes, thank you. Okay, there's another question, which is what would be the best way to ask about any concerns about treatment? Would it be more about asking how they feel about it, or would they feel better asking in a written format instead of in person, like a questionnaire?
Asking families how they feel about treatment.
If they have any concerns about treatment
Hmm.
and how they feel about it, both.
I think this does go back to every family is going to be a little different. I don't know about the written format. I feel like my immediate reaction to that is that tends to be the format families prefer the least in terms
Mhm.
of like giving some kind of feedback. Um, I'm gonna lean back on starting from, like, when I say this like collaborative kind of team building phrase that I feel like I keep using, I think I'm really saying like a humble approach.
Mhm.
Um, so my recommendation to that, and trying to lean back on what other providers had said, because humility came up a ton in these interviews, is acknowledging where the limitations are and whatever it is that you're introducing to a family, treatments included. So
Mhm.
things like, hey, and I'm PCIT certified, and use, like, I don't know if people are familiar with pride skills. I will be upfront with families and say, like, I'm a clinician. I have learned these skills that are evidence-based, but these skills, let's be real, they weren't designed for families who look like you or who look like me. So my job is to try to find a way for some of these skills within my skill set to best fit your family. And that's only going to work if we can team up here, and if you can let me know if this is just not a skill that you're really feeling right now.
Okay, thank you. And I
Yeah.
think that's all the questions we have for now.
Awesome.
Oh, one more. Okay, hold on, hold on. It just
Okay.
popped up. So Monique said, I am Brazilian, and these points mentioned by Latin families in this research reflect on my way of thinking. In my country, the relationship between patient and doctor is much closer than in the USA. If there is no simpatia and respeto, excuse my lack of an accent, medical treatment will not progress. My doubt is that American medical culture does not consider these points as priorities. How to change this medical system that is already so embedded in American society?
Yes. And to that point, I do have, regarding that third study that I'll very briefly talk about, I do want to make that bigger point of, I think there are at least some providers. I want to say maybe a lot, but I don't have those numbers. This wasn't a quantitative study. Where it does give me a little bit of hope of most of the providers I interviewed weren't familiar with this concept of simpatia, or were not Latina individuals, but they knew exactly what Latina families were looking for. And they had a lot of these qualities embedded within their service delivery. And yet there's only so much that they can do working in the system that they're working in. So I think there's a little bit of hope in that even these non-Latina providers are really embodying these cultural values, but more work needs to be done about how can we make sure that there is a setting that allows for this type of relationship building.
Sure. Okay.
Great.
So she said, thank you.
Awesome. Okay. So one thing that I've been thinking a lot about is from these findings, whether or not they are specific to the Latin American population, the Latina population. And answering that is already a very difficult question to answer because of the amount of cultural diversity present within this population. So this is introducing a little bit of the Latin American context, where we have the diversity in countries, in the extent to which they express these values. And here, I'm trying to remember the specific findings, but I believe within the study, Cuban Americans scored slightly higher than Mexican American populations on this cultural value of personalismo. There's also diversity in socioeconomic status, languages. This doesn't even get into the racial diversity within this population. But while there is diversity present within the Latin American population, and because we're in a country that sometimes or often treats us as a homogeneous monolith, there are also a lot of experiences that are shared among the Latinas in the US. We're often othered in the national discourse. A third of us are not proficient in English. And I was reading, I think it was the Pew Research Center site, I want to say 70% of us speak conversational Spanish. We experience access barriers to needed services. And we have a shared history of oppression as a result of unfair and unjust practices towards Latinas. Some examples include Americanization programs, which has had lasting negative consequences, such as in this example, which aimed to Americanize, you could interpret it as eradicate Mexican-American families' diets, which has had negative effects, including has contributed to a higher risk for obesity within this population. Also, the harmful treatment from US healthcare systems, such as the forced sterilization of Latina women, again, without their consent. This was within a prison system. And of course, the discrimination experience and distress related to immigration policies and anti-immigrant national discourse. So I think this is a really, both of these, thinking about the Latin American context is really important to remember as I'm talking about, hey, just embody connectedness or embody simpatía and respeto, because I think it's important to keep in mind that something like connectedness, if I'm comparing a Latin American family versus a non-Latin American family, especially if I'm thinking about like a white family who grew up in this country, who understands English, has a higher SES than maybe your Latin American family, the way that I approach connectedness, I would think it's going to feel different. This is not to say that other non-Latina populations don't want to feel connected to their providers, don't want to feel that commitment from providers. It's just, there's just a bit of a qualitative difference in how I as a provider would approach that. And same depending on like within the Latin American population, like the information that I might disclose about myself might look different if I'm talking to another second generation immigrant versus someone who immigrated from like Mexico. So that was examining a little bit about the Latin American context, but with regard to the provider's context and how this comes into play during the service interaction, I'll briefly discuss a third study about, I was examining providers' level of burnout and those consequences. I used a survey called the Maslach Burnout Inventory and found that most of the sample's providers, so again, this is the same sample, they experience elevated work exhaustion on a regular basis. So here exhaustion or elevated versus, it's elevated versus low levels of exhaustion. That's more about the frequency. So it's elevated means experiencing exhaustion pretty regularly, whereas low exhaustion means you experience it just maybe less frequently. And underlying this regular exhaustion is a high workload amount compounded by a demanding work content, such as honestly just working with a population that has a higher high support needs, and these tend to be marginalized populations. And also being a provider from a marginalized cultural background can underlie exhaustion. And in terms of the impact on care delivery, exhaustion relates to a negative impact on providers' work output, like more delays in their work tasks, and can have a negative impact on the families they serve, like having more last-minute cancellations on families. And interestingly, even the providers who experience exhaustion with less frequency still experience these instances where exhaustion has had negative impacts on their care. So again, these are the providers that when asked what are Latina families looking for in service interactions, they overlapped completely. So they know what Latina families are looking for, and yet these are providers who are saying, I don't, with this elevated exhaustion example, I don't want to turn in that report because I'm not proud of it. It's not a job well done because I don't have the time. This is not a good product. She said, I'm embarrassed to turn in an evaluation report that's going to be bad. But sometimes that's what I have to do because I just don't have the time. Whereas this provider with low exhaustion said exhaustion happened recently. It's where I can't talk to anyone for days. I've canceled on appointments. There was a time where I canceled 3 times on a client, and that's not okay. And that doesn't look okay to the family. And again, these were providers who knew exactly what these families were looking for, but they had moments of varying frequency where they feel like they just can't work to the best of their abilities. And I think this is so important to talk about, talking about burnout through a social cultural lens, because burnout is not an individual level condition. It's a symptom of a larger systems level problem. And I think this is starting to be recognized a little bit more, that if you have staff who are burnt out, it's not on them to build more resilience. It's on a larger, at the organization level, to make it so that this isn't as much of a thing, hopefully, or addressed at a systems level. Why do we have a system that is going to lead to a workforce that is limited because they're experiencing burnout, or leading to a shortage of your workforce because they've had enough? So like I said, avoiding burnout is not about building resilience at the individual level. It's about making sure providers have access to basic resources and safety, which includes job security, as well as ensuring organizations can guarantee its providers respect and appreciation, such as by respecting PTO time, ensuring that compensation reflects the value that's placed on the services and the skill sets that providers are bringing. And this does include the value placed on any providers who do speak Spanish, because I believe that speaking Spanish is definitely a skill set. And until we have more of a system that does reflect this, like addressing what providers need at each of these levels, we're going to keep coming up against, you could be the best provider in the world, but the system is not built for you to work to the best of your abilities at all times. Okay, so I'm gonna try to run through these because I'm not sure how I'm doing with time, but this is just kind of where I'm seeing as like the limitations, but also next steps for a study like this.
Sorry to interrupt. Someone asked, can you repeat the burnout scale that you used?
It's the Maslach, and I'm pronouncing it's MASLACH, burnout inventory. Right, so I think this is like a really big key or piece of the puzzle that's missing from this type of research, of better examining service system factors and how this how we can remediate some of the things that we're coming up against, and things being like having mothers of children with autism say something like, it's almost like you have to get a college degree just to navigate through all the services. And if you don't stay up to date on the services or on the insurance, you're going to sink and your child is going to fall through the cracks. And running up against things where there is little incentive to work with marginalized populations. If private insurers are going to pay nearly double Medicare rates, and if developmental behavioral pediatricians have the lowest lifetime earning potential, developmental behavioral pediatrics is the field that tends to work more with IDD populations. So to me, this is a big sign saying we don't really value this work and aren't really willing to compensate for give compensation that's really reflecting the amount of work that could go into these fields. I'll mention, I did aim to recruit caregivers, grandparents, fathers. Mothers was just who responded and who were like wanting to participate, but I would really love to see more research that does include more perspectives from fathers, grandparents, and also from the individuals with IDD themselves. And this is just a summary of what I have been talking about. And at the end of the day, yes, cultural values, Latino cultural values are going to have a really, really big influence on preferences for service interactions and also how families behave. So I do think it's good to try to think back on what these values are and try to make those connections in the moment. And yes, context influences both preferences, perceptions, and behaviors on both the caregiver and the provider. Okay, so I will stop there, ask if anyone has any questions, and I also included my contact information. If anyone has any questions after the fact, both little or big, feel free to reach out to me. I'm seeing.
Thank you so much. And I'm just looking to see if it will give some people some time to post their questions.
Sure.
So while we're waiting on that, I'd just like to remind everyone that we have an Autism Consortium of Texas meeting next month, and that will be on November 10th. It'll be Dr. Michael Siller joining us from 12 to 1:30, and it'll be on the topic of supporting children with autism in naturalistic settings, creating an ecosystem of care for autism. So put your email in the chat if you would like to receive a notice about that, and we will be offering CEUs. And we do have a couple questions now. So, okay, the first question, it's a question or a comment. I totally agree with your findings. Once Latinate families find a provider we like, we're loyal. And then someone said, what are your future plans for research topics? Such a great presentation. Thank you so much.
Absolutely. Regarding the loyalty comment, I did kind of gloss over. I mentioned that Latina families, once they find their person, you are their person. So if there are providers on this call, one thing that I will mention is I did have some providers mention how, and sometimes it was a lot of like texting on the weekends and that kind of stuff. But generally speaking, providers mentioned that they set some boundaries and the reaction to that was positive. So I think I wouldn't shy away from becoming someone's person is basically what I'm trying to say. That loyalty can maybe feel a little overwhelming at times for providers. My future plans for research topics, I'm currently working at Nemours Children's Hospital, and I'm trying to start a study looking a little bit more, shifting a little bit more to some quantitative work on how we can bring autism diagnostic practices into primary care settings. Just trying to address the issue of you can refer to a specialty center, and I just don't know that how many families aren't really following up on those referrals to specialty sites. So trying to make that more in-house within primary care centers is my next step. But thank you for asking.
Mm-hmm. Let me see if we have any more. Okay, if anyone has any additional questions, please put them in the chat. We'll give them a moment.
Okay. These were great questions, by the way.
So Lily says, what changes to graduate medical school coursework or internship training would you recommend based on the results of your research? You mentioned that most training is focused on developing expertise rather than some of the other skills that are especially important to Latinate families.
Great question. This actually feels like a question that I asked almost exactly to the word to participants in this study. And I think from providers' perspective, almost like a unanimous response was, this shouldn't be a part of a classroom. This isn't really like coursework. For these providers where they really felt like they developed some expertise in working with more diverse populations, with marginalized populations, is just hands-on learning. So really emphasizing, like in terms of something that could be changed, I would say going back to those incentives, creating more incentives for providers to choose practica, residencies, and postdoctoral fellowships that can really give some hands-on experience and hands-on training on how to work with marginalized populations. Because that's what these providers are really crediting. Like I asked, like, where does your confidence come from in working with these populations? And it really did come down to just years of experience and being willing to work with these populations.
Thank you. Okay, so I don't think we have any more questions at this time. I'd like to ask everyone to please complete the evaluation that will be sent out to you. We put the link in the chat, but you'll also receive it once the presentation is over. And we so much appreciate you joining us, Dr. Gordillo. It was a really helpful topic, and we appreciate everyone who joined us today. Thank you so much.
Thank you for having me.
Yes, thank you. Thanks, everyone. Bye.